Welcome. In this lecture, we'll be discussing multiple sclerosis. MS was first described by Jean-Martin Charcot in 1868. It is the most common cause of demyelination in the central nervous system, and the term multiple refers to the presence of multiple areas of demyelination scattered throughout both the brain and the spinal cord. The pathology of MS is thought to be stepwise, first beginning with some sort of autoimmune trigger. This means that either an environmental or genetic susceptibility triggers an abnormal immune response against CNS myelin. This leads to the activation of CD4 plus T cells, especially Th1 and Th17, which becomes more sensitized to something known as myelin basic protein, or MBP. This can then cross the blood-brain barrier and initiate inflammation. T cells release cytokines, which can recruit macrophages and microglia. These immune cells can actually attack something known as oligodendrites. Oligodendrites are special cells in the CNS that make myelin, the protective covering around nerve fibers. Thus, when the oligodendrites are attacked, this leads to demyelination and impaired nerve signaling. Finally, we get something known as plaque formation, as the damaged areas form sclerotic plaques, typically seen on MRI. Simply put, MS is an autoimmune CNS disease where T cells attack myelin, leading to inflammation, demyelination, and axonal damage, resulting in neurologic deficits and plaque formation. MS has a large multitude of different risk factors. Like many other autoimmune diseases, this is highly susceptible to females, typically between the ages of 20 to 40. MS is also associated with HLA-DRB1 because this specific human leukocyte antigen, or HLA, plays a key role in presenting antigens to the immune system. So in genetically susceptible individuals, HLA-DRB1 may more effectively present myelin-related peptides, like the myelin basic protein that we just discussed, to CD4 plus T cells, causing an autoimmune response. EBV may trigger MS by promoting autoimmune attacks on myelin through molecular mimicry. In fact, nearly 100% of MS patients are EBV seropositive, compared to only roughly 90% in the general population. Vitamin D deficiency is also highly associated with MS. Vitamin D supports immune regulation, and deficiency may promote autoimmune responses that contribute to MS development. For the boards and for exams, look for terms that may suggest vitamin D deficiency, such as colder climates or being further away from the equator. A mnemonic to help remind you of this is something known as very high exposure brings MS, or VEB, where V stands for vitamin D deficiency, H for HLA-DRB1, E for EBV infection, and B for being female or latitudes, higher latitudes being further away from the equator. Now, multiple sclerosis has very unique presentations, but let's first discuss the most common presentation that you may see on your exams. The most common subtype is known as relapsing and remitting, and is typically makes up 85% of all individuals with MS. These lesions are separated by two things: space, meaning that they present differently each presentation, and time, meaning that they occur more than once, or two or more times through someone's life. Now, the most common first lesion is actually something known as optic neuritis, which we will discuss later on in this lecture. But you may also see a rare but classic cerebellar triad known as Charcot's triad, named after its founder. You can use the mnemonic SYN to help remind you of this triad. S stands for scanning speech. The speech sounds slow, broken speech, typically with pauses, due to impaired coordination of the muscles used for talking. I is for intention tremor. And intention tremor is shaking that happens when you try to do a precise movement, getting worse near the goal. And then, of course, N for nystagmus. Typically, we see central vertigo or central nystagmus. We have a whole lecture depicting peripheral versus central nystagmus and vertigo. But typically, this is vertigo or nystagmus that lasts greater than 1 minute, is continuous and non-fatigable. Please note that SIN, or this cerebellar triad, is typically only seen for these three, but you can also use the I to remind yourself that INO and urinary incontinence is associated with MS. Now, there are other presentations like fatigue, spasticity, and numbness and tingling that can also occur in MS. Now, a mnemonic to help remind you of this common presentation is something known as MS WINS, where M stands for motor, such as spasticity or weakness, S for sensory, such as numbness or tingling, W helps to remind you that this typically takes place in females or women between the ages of 20 to 40, I is INO, internuclear ophthalmoplegia, which we'll discuss in the upcoming slides. N for neuroocular, the most common first lesion is in optic neuritis. You may also see diplopia or double vision. And then S for scanning speech. This mnemonic is for the most common presentation. Now let's talk about unique presentations. We'll first discuss these 4 here, and optic neuritis we'll cover later on in our lecture. Lhermitte sign is a shock-like feeling down your back and your arms when you flex your neck. You simply ask the patient to look down at the ground, and if they have lightning-like, shock-like, or even numbness or tingling down the bilateral arms and or back, this is highly suggestive of Lhermitte sign. Lhermitte sign is classically seen in MS, but for board purposes, please be aware that Lhermitte sign is also seen in cervical myelopathy. The Uthoff presentation is actually when heat makes MS symptoms get worse. Heat actually slows nerve conduction. So in already demyelinated axons, this can lead to symptom flare-up. These 2 presentations are very commonly seen in MS. We also have another unique presentation known as internuclear ophthalmoplegia, or INO. This is caused by damage to the medial longitudinal fasciculus and affects the ipsilateral cranial nerve 3. So whatever side the MLF is damaged on, it's going to affect that same side's cranial nerve 3. This leads to the inability to adduct the eye. Now, whenever you see the term medial longitudinal fasciculus means that there's some sort of communication that's taking place between 2 nuclei. So let's discuss the motor function of the eyes in this diagram. So let's say I want to have my eyes look to the right. That means my right eye has to look right, and my left eye also has to look right. So in order for this to take place, I need to abduct my right eye and adduct my left eye. This is done beginning with something known as the frontal eye fields. This is part of your motor function located in your frontal cortex, and the left side of the brain always communicates with the right side, right? So if I want to look right, my left side needs to be active first. So my left frontal eye fields go to the contralateral side and communicate with something known as the paramedian pontine reticular formation, or PPRF. From there, the PPRF signals to your abducens nucleus, your cranial nerve 6. The cranial nerve 6 needs to do 2 things. It needs to communicate with the ipsilateral lateral rectus in order to abduct, in order to look right, and it needs to communicate with the ocular motor nucleus on the other side, on the contralateral side, in order for the left eye to also look right. It does this via something known as the medial longitudinal fasciculus. Thus, this fasciculus, in this case, communicates between cranial nerve 6 and cranial nerve 3. If I have damage to my MLF on the left side, this is going to mean that my ipsilateral cranial nerve 3 nucleus is going to be damaged. This means that my left eye will not be able to look to the right, aka will not be able to adduct the eye. And that is exactly what is taking place in this image here. Now, for the exam purposes, bilateral lesions can be seen in MS. If you ever have bilateral cranial nerve lesions, always think of MS, and INO is the exact same way. This will be the inability to adduct either eye. The same thing goes for your trigeminal neuralgia. Trigeminal neuralgia is an intense electric shock-like pain that affects the face, typically due to demyelination of either the trigeminal nerve nuclei or the nerve root, which causes improper signaling of the nerve and can cause severe pain. This is pain typically when you brush your teeth or cold air hits your face. And if you have bilateral trigeminal neuralgia, always think of MS. Now let's discuss imaging. The best test is going to be MRI. This is actually the only diagnostic test that we need and the only imaging that we need in order to diagnose MS. And typically what we need to do is we need to get an MRI of the brain and all of the spinal cord. What we may see is periventricular lesions or juxtacortical lesions. Periventricular lesions are MS plaques that form around the brain's ventricles and are bright spots in MRI. That's what is seen here. These bright spots are periventricular lesions right around the ventricles. And then, of course, juxtacortical lesions are MS plaques located near the brain's outer layer. These are seen on MRI as bright spots, and that's what these arrows here are actually pointing to. Those bright spots are juxtacortical lesions. You may also see something known as Dawson's fingers. Dawson's fingers are better seen from the sagittal viewpoint. These are fingers that point away from the ventricles. I always remember it as the fingers point to the ventricles. Really, it should be away from the ventricles. But these little tombstone-like projections almost, those little finger projections are known as Dawson fingers. And those are hallmark findings seen in MS. Now, although MRI is the best test and the only test in order to be diagnosed, diagnostic of MS, you may also get CSF findings, specifically CSF electrophoresis findings. What we're looking for is something known as oligoclonal bands of IgG. And these are immune proteins found in the spinal fluid that suggest inflammation in the brain or the spinal cord. This is detected via CSF electrophoresis and is found in 95% of multiple sclerosis patients. This can help support the diagnosis of MS when the clinical and MRI findings are not confirmative. So this is only typically done when the MRI brain is not really super helpful. Now, this is exactly what these IgG bands look like. On the left side here, we have normal. On the right side, we have abnormal. This increased darkening down here, this increased deposition are your IgG bands. Remember, electrophoresis separates proteins by charge. So to find the IgG bands in the CSF that typically aren't in the blood, this means that the immune system is active inside the brain or the spinal cord, but not in the blood. And that's exactly what's going on here. Now, this is the most high yield CSF finding, but you may also see myelin basic protein. Remember, we've been talking about that a lot, especially in the pathology, or MBPs. This is not as commonly tested, but is also something I want to make you guys aware of. These are not required for the diagnosis, but they are board favorites. So what exactly is required for the diagnosis? Well, we use something known as the McDonald 2017 criteria, which states that you must have dissemination in two things, time and space. Remember that presentation that we talked about, space and time. So what exactly does this mean? So time, this needs to occur more than once or two or more times. So you have to have two or more MS attacks at different times. And you have to have space. So you have to have lesions in two of the four following areas or following spaces. Periventricular and juxtacortical, which we just talked about, infratentorial, and of course spinal cord. This is why when you get the MRI, you always get the MRI also of the spinal cord. Note that in order to diagnose this, you have to have clinical symptoms, time, and you have to have physical symptoms on imaging. So you need both imaging as well as clinical symptoms to diagnose MS. Now let's discuss the treatment. The treatment is going to be broken down to acute flares versus chronic treatment. For acute flares, it's very straightforward. Typically, the whole hallmark is going to be IV steroids, most commonly methylprednisolone. This helps to resolve symptoms, but it does not actually improve outcomes. This is just for symptomatic relief. If an individual is non-responsive to the steroids, you can consider plasmapheresis, but for the most part, steroids should be enough. Long-term treatment is where you're going to have most of your questions come from. Now, interferon beta is a first-line MS therapy that reduces relapses by modulating immune activity. The side effects for interferon beta is going to be flu-like symptoms and elevated liver enzymes. Fingolimod is an oral MS drug that blocks lymphocyte migration into the CNS. The main side effect here is bradycardia, although it can be associated with macular edema and infection risk. Actually, after receiving this medication, you need to stay in the outpatient setting for 6 hours for monitoring purposes to make sure you don't get bradycardia. Natalizumab is a potent MS monoclonal antibody that blocks lymphocyte CNS entry, but carries a serious risk for PML, especially in patients with JC virus. So this is associated with the development of progressive multifocal leukoencephalopathy, PML. It is highly recommended to test for antibodies against JC virus before starting this medication. So we always look for JC virus antibodies. If you have them, you should not get this medication. Now, for completeness sake, there are over 20 disease-modifying therapies that exist now, and outcomes are getting dramatically better compared to treatment just decades ago. Thus, there is a lot of new treatment options and medications out there, but these are still the three most commonly tested. For other symptoms like spasticity, baclofen or tizanidine can be given. These are your hallmark for spasticity treatment. Now, let's discuss the most common presentation, optic neuritis. Optic neuritis is due to demyelination of the optic nerve, which causes inflammation, hence the term itis. This is due to nerve sheath swelling and myelin breakdown. Now, the most common risk factor is going to be multiple sclerosis, but there are other causes of optic neuritis, and that's why I wanted to discuss this separately. Another very common cause is ethambutol. This is part of your RIPE treatment. This is the E in RIPE for your TB medications. The most common side effect is actually optic neuritis. Thus, be aware on test day when you get a similar presentation and it doesn't sound very MS-y to you, think of other causes. Most commonly, it will probably be medications like ethambutol. Other infections such as Lyme, syphilis can cause it, and you can also have ischemia cause it as well. The symptoms here is going to be monocular pain, so eye pain, worse with movement, due to the itis, the inflammation, and sometimes decreased visual acuity. If they give you physical exam findings, thus they look into the eye, you may see optic disc swelling. Here's a normal optic exam, your optic disc and your optic cup, right? Here is the swelling that we can see in optic neuritis. You should be able to see how much more wider this area is comparatively to normal. This would be your swelling that you can see. The diagnosis is typically clinical, but always in optic neuritis, we always want to get an MRI of the brain and the spinal cord to look for potential MS, because that is the most common association. And then the treatment, because it is inflammation, is going to be high-dose steroids. And that concludes this lecture on multiple sclerosis.